Okay, we're going to go ahead and get started. Welcome everyone to the Innovations in Community Care 10-week lecture series. It's a series of brief talks on important topics in family medicine, community medicine, delivered by our Wright Center National Family Medicine Residency Program faculty. Each week, one of our faculty members from one of our 4 training sites in El Rio in Tucson, Arizona, or HealthSource of Ohio in Hillsboro, Ohio, or HealthPoint in Auburn, Washington. Tonight, we have Unity Healthcare in Washington, D.C. speaking to us. Our program is the largest ACGME accredited program as a teaching health center program in the country, and we have 50 residents. We also are in partnership with ATSU SOMA, A.T. Still University School of Osteopathic Medicine in Arizona. At the conclusion of tonight's session, you'll have the opportunity to speak with our residency faculty that are in attendance. Now I'm going to turn it over to Dr. O'Donovan and Dr. Ebrahim, who will introduce themselves and begin our presentation. Dr. O'Donovan, you're still muted.
Okay, now we're cooking with gas. Sorry about that.
Yes, we can see your slide deck. It's not in full.
It's not in present mode. Let me just make sure it's in present mode. Okay, let's go back to that. Okay, now we're good. So hello, everybody. I'm Eleni O'Donovan. I'm the Director of Correctional Medicine for Unity Healthcare. Unity is DC's largest network of federally qualified health centers, which means that we are a government-funded network of community health centers caring for DC's most vulnerable patients. I've been with Unity almost 14 years, and I started there after residency as a National Health Service Corps scholar, working both at the Department of Corrections and then in the community. So splitting my time between the two environments. I'll let Dr. Ebrahim introduce himself.
Khalid Ebrahim. I'm an internal medicine and pediatric trained.
You just cut out. Ooh. Dr. Ebrahim, we heard you in the beginning and then you cut out.
Can you able to hear me now?
Yes.
Okay. All right. I'm an internal medicine and pediatric trained physician. I've been with Unity Healthcare for this is my 3rd year. I split my time between the community and also work at the Department of Corrections. And I also do some teaching at one of the clinics for Unity Healthcare.
Great. So our goal is to talk only for 18 or 20 minutes and just to introduce one of the special areas of medicine that Unity does in Washington, D.C., and that's providing the health services at the D.C. jail. So, we just hope to provide an overview of our healthcare model, kind of talk about how folks get to us, maybe to the ER, go over some common barriers of care. So, before I kind of start with the big picture for incarceration in the US, it's probably helpful to know a little bit more about Unity. So we really run our health services at the jail as another federally qualified health center. We've been there since 2006. We are a contractor when we are there, so it's a little bit different than running our own clinics. It's a government-run facility, so there's no private corporation. There used to be. but that contract ran out a few years ago. So it's now, the jail is run by the city and they contract with Unity to come in and provide full spectrum primary care services. But I think to understand what it's like, maybe a little bit both to be in jail and to work there, it's helpful to understand kind of the social medicine aspect of carceral medicine. So this is a slide that probably, and a statistic that other people have seen before, but the US incarcerates a lot of people, right? So we have about 5% of the world's population, but we incarcerate 25% of the world's prisoners, right? So that's much more than any industrialized country, and even more than many large countries like China. I mean, we put a lot of people in jail and prison. And that has a big impact on society. And it also really puts into relief some of the structural issues that we're facing right now in terms of structural racism and other kind of structural issues that lead to mass incarceration. So these statistics have changed a little bit over the past few years. They're the most recent, but what I'm reading over the past 2 years, the percentage of Black men put into jail and prison has decreased a little bit, especially with COVID. But pre-COVID, we were incarcerating about 1 in 3 Black men in this country in their lifetime, about 1 in 6 Latino men, and 1 in 17 white men. And these are actually the statistics in terms of impact on family of children who have, who in their childhood between the ages of 0 and 18 experience having 1 or 2 parents in jail, right? So the risk is 1 in 9 for Black children, 1 in 28 for Latino children, and 1 in 57 for white children. And so what these statistics mean, whether you're looking at, I'm just going to go back for a second, when you're looking at incarceration rates here for men, it's very similar for women. We incarcerate way fewer women, but the disparities exist. Or thinking about the impact on families, what it means is certainly for a primary care physician, for a family doctor, but really for any physician or clinical provider over his or her or their lifetimes, you will have contact with people who are impacted by incarceration. There's just no way that you won't. It's not something that we routinely always ask about, but it can be a really important part of someone's history. So just as a visual, this is the top left is where Dr. Ebrahim and I work. That's the building that we work in. The jail in DC is actually 2 buildings, an older one and a slightly newer one connected by a catwalk. But the majority of residents are incarcerated in this building, the Central Detention Facility. That on the top right is the picture of a jail cell, just to give folks a sense of what that might be like. I think sometimes our images of what jail cells look like are for the vast majority of people from movies and television shows. Sometimes they're right on. And sometimes they show much lower security facilities, kind of like Orange is the New Black, where there's a lot of movement and a lot of group. People are really housed in kind of more dormitory, larger group settings. But where we work, except in a couple of very specialized places like our infirmary, there are never more than 2 individuals to a cell. And during COVID, it's frequently 1. So that's a picture of one of our jail cells, one that's actually fairly nicely painted actually. And then at the bottom is not a picture of the DC jail, it's a nearby jail, but it's pretty much what our jail looks like. So it's usually 2 floors, 2 tiers, we would call it, with the jail cells. set up like that. So just to give people a visual. So jail, wherever you are, will very much reflect kind of the city, the town, the county that you live in, with some racial disparities probably. So in the DC jail, and it will be overwhelmingly male, right? Unless it's a dedicated women's facility. So 92% of our inmates are male, 92% are Black. In DC right now, it's about 57%. DC is a majority Black city still, but just barely so at this stage. 36% are not sentenced, they're actually pre-trial, and 25% are fairly minor violations, so parole, violating parole, and violating probation. I think that's an important thing to think about. People don't always understand the difference between jail and prison, but at jail, you will often have a lot of people who really aren't sentenced yet. They were arraigned and a judge sent them to jail to await trial. So it's pretty typical to have a significant proportion who have not been sentenced. And correctional health programs come in lots of different flavors. Ours is a very, very special model. There are just a couple of other federally qualified health centers that are involved in carceral medicine, and no one really has a program like us. So typically what you hear in the news is about private corporations. They're the ones that often get in trouble and are often in the news for bad health outcomes. You can have government contracts, so that's the second most common thing. So maybe at your county jail, you might have a local doctor who contracts with the county jail and they come in and see patients once a week. There are academic correctional health partnerships. So places like UCSF, the University of California in San Francisco has a relationship with their local jails and prisons providing care. And then there are nonprofits like us. There are probably other models, but those are the four most common. So, part of, I think, having myself and Dr. Ebrahim talk tonight is just kind of giving a different vision of what jail docs are like. There's a lot of different images out there. I did a presentation with medical students. We did a word cloud, and these were some of the things that they put into that word cloud when I asked them, like, what do they think about for jail and prison doctors? So the biggest thing, there's this kind of myth that that's where people end up who can't get a medical license or who had to leave residency. That probably used to be true more and is still true in some places where it's hard to recruit. Not necessarily unlicensed physicians, but historically, sometimes, especially rural jails on the border, things like that, that may have been true, but I think that's changed a lot over the past few decades. People think jail and prison is scary. People think we're in it for the money. There was the obstetrician in the South who was at one of the immigration detention facilities, and it had turned out that in his community he wasn't doing good patient consent and was doing hysterectomies on women coming from that facility. So I think at that time that was in the news, so uterus snatcher came up. And then people, I think, recognize that there also might be a mission component to it. That this is a place where people are very vulnerable and have a lot of untreated conditions, in a place where someone might do some good. There are other thoughts as well, but those are the ones that stood out. So this is a picture of real jail doctors. So these are three of Dr. Ebrahim's and my colleagues, one of our assistant medical directors, and then actually two of our former residents. So one of the wonderful things about our program is our residents all rotate through the jail. They do a month focused on correctional medicine. It's a combination of readings and reflections, and then spending some time at the DOC. So Dr. King, who's the top right, and Dr. Suzuki, who I think is on this call tonight and is in the middle, both trained with us and then chose to continue to practice. So it's a great example of training in place and probably changing somebody's mind about what it might be like to work in the jail. So we practice something called community-oriented correctional health care. That's a real thing. There's actually a society for it based out in California. And they define it as reframing jail healthcare so that you don't think of it as a separate entity, but that it's a delivery site, kind of like we think about it. It's a clinic within the community. And I will say that I think the biggest takeaway that people have, whether they come from residency like Dr. Ebrahim and I did, or whether they're a learner, a medical student, or a resident coming in, is the realization that the patients in the jail are the same patients that we see in the clinics and in the hospitals. Like, they really are community members. And it demystifies it pretty quickly once you see a few patients and start talking to them. So our model is that our providers practice both in the jail and in the community. I call it the come with me model. The idea is you can meet patients who aren't connected to primary care, get them connected while they're in jail, and then have them follow up with you. And that does happen, especially for our HIV patients, actually. About 40% of them see our infectious disease and primary care docs in the community. It's about 20% for the rest of our folks. We do a lot of discharge planning, making appointments for people. We do give medications on release, including with prescriptions. While we're only able to give about a 3-day supply of something like a high blood pressure medicine, we have separate funding streams for a couple of special programs. We actually are able to give 30 days of HIV meds and 7 days of Suboxone through our medication assisted treatment, or MAT program. I'm not going to read this in detail, but these are all the things we do at the jail for patients. We have a lot of providers. We staff 24/7, 365 days a year. Some of our specialized programs, I mentioned medication assisted treatment for folks with opioid use and alcohol use disorder. We have a lab, we do x-ray, and we have a bunch of specialists who come in. And I also mentioned that we have discharge planners who meet with patients, focusing on the ones with chronic diseases, making sure they get linked up to care in the community when they leave. We have very good outcomes. So we compare our DOC patients to our regular Medicaid patients in the community, figuring that's a pretty fair comparison, because most of our DOC patients, when they're in the community, have Medicaid. And, just looking at two pretty simple measures, diabetes control and hypertension control, we do better at the jail. That is, probably partially because we deliver their medications to them. So medication adherence is likely higher. We don't have to do a lot of social things for them. You really can't work actively on people's housing issues or on even their legal issues necessarily. There are other ones like getting evicted or things like that while they're in jail. So we really get to focus a lot on the clinical medicine. And I think, people are attracted to carceral medicine for different reasons. One of the things, I think, if you're, a regular factotum in family medicine or med peds, right? We do all things. We see people through the lifespan. We do lots of different things in medicine. You get to do a lot of interesting things. So there's a big infectious disease component. We do MAT. We see a lot of mental health. This is a not surprisingly, highly traumatized population. So we really try and use a trauma-informed care approach. You see people with a lot of brain injuries because there's so much violence. We do a lot of musculoskeletal injury and trauma care. And then we have not surprisingly, a higher proportion of folks with learning disabilities and cognitive issues. So there's a lot of interesting stuff that walks through the door. So we're going to wrap up in a second, but I thought it just might be useful to kind of talk about a typical patient and how he or she or they might walk through the jail. So 45-year-old male who has high blood pressure and opioid use disorder and hepatitis C. He misses a court date. He got out of jail a little while ago, never got around to getting a new cell phone, so misses a court date, and then violates parole, kind of unintentionally. That's a pretty typical story. So they put a warrant out for his arrest because he's now a parole violator. They pick him up. He'll get arrested. He'll get booked at a local precinct. He'll go to lockup, right, under jail custody, and then he'll get arraigned from this main facility that's downtown. And in this instance, maybe he gets 90 days for violating his parole, and he comes to the jail, and he comes to intake, what we call the inmate reception center, which is a big clinical area. It's kind of like the welcome center of the jail. And so people get showered, they get searched, they're kind of given the basic things they're going to need in jail, and then they immediately come to medical. And in intake, it's staffed with providers. So PAs, nurse practitioners, physicians, they get a full physical, they get a mental health screen. We also have a behavioralist there and often a psychiatrist. We do infectious disease screening, which now includes COVID-19. And if that person's in withdrawal and meets the criteria in our protocol, which is based on the SAMHSA protocol that everybody pretty much uses for MAT, they get started on MAT right there, then and there, on Suboxone usually, although we can also start people on methadone. And then they'll get scheduled into our primary care clinic, what we call chronic care. And there they'll see a provider for a regular visit. The provider will get some more history, just do your vision of a typical primary care visit. Maybe they'll get some more labs. Maybe he needs his cholesterol checked. Maybe the provider finds out that he's never had treatment for his hepatitis C. It's possible that we diagnose it from his intake labs. He'll see a dedicated MAT provider. We'll talk to him about his substance use and also hook him out with up with our counselors. And he'll probably get a referral to our infectious disease clinic because we treat hepatitis C at the jail for folks who are going to stay long enough and who have kind of moderate to advanced disease. So he'll get staged, and if he's got kind of fairly significant fibrosis, we'll start him on hepatitis C treatment. And if he stays for 8 weeks, he'll probably be cured while he's there. Then he'll go on and he'll definitely interact with behavioral health. Pre-COVID, he probably would have been in a substance use disorder group. With COVID, we're doing more individual treatment. We have peer navigators. We have certified addictions counselors. So he'll interact with that team. And as he's getting ready to go at the end of his 90 days, a discharge planner will meet with him. If he isn't really hooked into primary care in this instance, the discharge planner will offer the patient an appointment with the infectious disease physician that they've been seeing in jail to follow up for the hepatitis C. If they've connected with a primary care doc, they'll try and make it with that primary care physician at that clinic if it's convenient for the patient. And then at release, someone will order the patient release medications. So if he, for instance, is going to continue Suboxone, he'll get a supply of Suboxone, he'll get his prescriptions, he'll get his blood pressure medication. And if he hasn't finished his hepatitis C treatment, he'll be given a few pills and a prescription for that. So that's kind of how people walk through their experience at the jail. So there's lots of reasons people like to work in jails and prisons. I think Dr. Ebrahim and I probably have some of the same and then some different reasons that are listed here. This is actually from a study that did focus groups with carceral providers. And these were the most common things that were talked about. So salaries are often quite good. The hours are very predictable. It's a little bit more like shift work. There's not as much administrative burden, right? And as I mentioned, there can be really challenging pathologies and cases. We see things like Kaposi sarcoma, which there will be probably at this point in the development of antiretroviral treatment for AIDS and our guidelines now, that may be something no one ever sees again in some, medical careers. There's a lot of autonomy. We're pretty independent in the way we practice. And then again, there's the mission. So I'm going to end there. I will leave this slide up in case anybody on the call tonight is really interested in learning more about correctional health care, more about incarceration and the mass incarceration situation in the US. There's a couple of really good books, and the documentary 13th is another really good place to kind of get a good overview and the history of incarceration in the US. So I'm going to turn it over to Dr. Ebrahim and let him talk a little bit about why he does what he does.
All right. Thank you, Dr. Donovan. I think just kind of reflecting on my experiences working at the Department of Correction, as you put up the list, the main thing was coming out of residency, I didn't expect to be working at the in a correctional setting, but it's been an eye opener for me personally to see the breadth of pathology, the similarities of working just in the community, and also the autonomy. I think those are the main things. And also in the background, you also realize kind of puts you at the forefront of like just working just in the justice system and how the injustice that you face, and you kind of start reflecting on how you can help the residents and the patients there. There's been multiple situations where you've seen patients in the jail, and then we also meet them outside in the clinic, and that's been rewarding to take care of patients to transition from the jail to the community. So it's been an amazing experience. And every day I keep learning something new. There are some challenging parts of working in the jail, but overall, I think that I've been very much appreciative. And every day I kind of reflect on my day when I leave the jail, and I say that it's always interesting to work in the jail, and I learn something new every day. So.
Thanks. I think we're open to questions at this point.
Yeah.
Yes, we are. Any questions from our attendees?
I have a question. Can everyone hear me?
Yes, go ahead.
Hi, my name's Emily. I'm a third-year medical student at A.T. Still University in Arizona. Hi, Dean Morgan. So medical mistrust is a big issue in most or probably all marginalized populations and communities, but particularly the incarcerated population has this long history of medical experimentation and a lot of things like that. I was wondering if you've found medical mistrust to be a challenge as a provider, and how do you overcome that so that you can care for your patients?
I think, yeah, it's very true. There's a lot of mistrust, and that's a daily challenge for us as providers. But you would be surprised to find that we get to know the patients very well. We typically see especially working in chronic care, we see the patients all the time, and you actually build a rapport with the patients. You find a way to like present information in a sense that so they feel that they're respected. I think that's a big thing in the jail. They're dignified, and if you're able to present the information in a way so that they feel that you don't see them as you don't present it to them, and they don't feel that there's a mistrust. The populations at the jail, they're very much aware, and they can kind of read your body language, the way you present things, and they can pick up right away if there's something that feels dishonest to them. So it really it's a challenge every day, and we continue to build rapport with the patients. And once you kind of get to know you've earned their trust, and it's actually quite a rewarding experience. We get them to they're very informed, and we provide a lot of patient education, and then they make informed decisions because they have a lot of time to read about the pathologies and things like that we present to them.
Yeah, I would also say that, and it's true, and I can, talk a little bit about, for instance, COVID vaccine hesitancy, right? So we're vaccinating at the jail. We're also really very respectful of folks' right to not get care. And so I think often that's a pretty common reaction, like you'll suggest something or offer something, and I don't want it, and it's very, sort of aggressive, and our response is, okay, we are not forcing care, right? Provided they have capacity, and if they don't, it's a big deal. It is not at all one flew over the cuckoo's nest, for instance. Like, we do not hold people down and force injections. Like, something like that is so incredibly rare. We really respect their autonomy and their ability to make medical decisions for themselves. And I think once they realize that, and as Dr. Ebrahim was saying, there's actually a good amount of continuity. It's a jail of about 1,600 people. And that's actually fairly small. And for the folks who access care pretty frequently, we see them a lot. So I agree. A lot of it's relationship, but there's also, it's just so different from the community, right? You really never in the office, like, go in and expect a patient to immediately be like, you can't make me do that. Right? That's just not a conversation. We have that conversation like 10 times a day at the jail, because they were getting made to do everything, right? Like, almost every single thing, sometimes even every single thing, including like when someone can go to the bathroom, is dictated. When you get fed, when you eat it, when your tray is picked up, when, what you're eating, all of it. So I think, once they realize they have that autonomy, often it kind of deflates and they're pretty collaborative. But it definitely exists. I was counseling an older individual who's been in and out of the system since the 70s about COVID vaccine. And he said, I'm not taking that. And I said, oh, okay, do you want to tell me what you're thinking? And he said, I was in Jessup when they did the malaria vaccine trial in the 70s. My cellie is what they say. My cellie was never the same. I had no idea about those vaccine trials. And then I went and actually a colleague of mine found the New York Times article from when that vaccine trial was shut down and deemed unethical. And it was, right down the street in Maryland. And this guy had been a part of it. And he wasn't having any more. And it's really, what do you say to that? Except, I get it. Please wear your mask. Let me give you some information and let me know if you want to talk about it again. So I don't know, Dr. Suzuki, you're on. Do you have anything to add?
Sure. Hey, everyone. I'm Taisei Suzuki. I'm one of the provider at the jail as well. I'm also the product of this residency program. And one of the uniqueness of our program is to provide, especially at the Washington, D.C. site, provide the rotation at the correctional medicine, which is very, very unique. And I was fortunate enough to get robust training during my residency program. My own experience to answer that question is I typically find a lot of my patients have never had any opportunity to be listened. So whenever they come, like Dr. Donovan and Dr. Ebrahim already said, that they're kind of instantly shouting. They are trying to get their point across by basically mean of shouting, because that's the only way that they've been heard. So when we take a moment and then listen and then say, hey, I'm just here and I'm curious about your health, and that's only what I care, that kind of opens up a lot of doors. Like, oh, okay, so this guy just want to listen to me and actually try to help me. And that rapport gives a lot of doors to open and access to the care that they may never had. So it was interesting. And then also, sorry, Emily, I know you're DO students too. I'm also DO, and I provide the manipulation in the clinic too, in the jail. And what I find is that a lot of people have never even touched, like being cared by even family members. So once I started doing some manipulation, they started opening up and talking about their family members and what they've been going through. And then sometimes they started taking more medications, even though they were resistant at the time, or they were not even listening a lot of nurses or doctors, but they just turn around and they're like, hey, they were there to kind of help me. So that was kind of eye-opener in the past couple of years that I've been practicing at the jail.
Thank you so much for sharing your input. And Dr. Suzuki, I think that's so cool that you provide OMM and OMT for patients, because that's something that I see a lot of patients at our community health clinics. They also don't always have access to that. So the fact that incarcerated patients are getting access is super cool. A bit of a logistic question, unless someone else wants to ask a question. I don't want to.
No, go ahead.
Okay. This is more of just a logistic question. Do you find that you have more time seeing patients here than when you're at the FQHCs?
Yeah, I think everybody's kind of nodding. Yeah, and again, actually, it's interesting. We probably don't take a lot more time than you would. Like, I mean, sometimes you'll take 20 or 30 minutes because you're going to do a procedure or something. But if everything else falls away, this is kind of the magic of jail. There's no insurance. Again, there's no, we do make outside referrals. If somebody needs to see a urologist or an oncologist, that can happen. But other than that, and it's a pretty straightforward process, we're not doing any of the other stuff, maybe giving patient education. But if you kind of strip away a lot of, the social medicine, which we all love, right? We're all community docs. In some ways, like, it is the most intense form of social medicine because of the setting, but most of the time we really just get to do medicine. Again, because there's not a lot people can work on when they're incarcerated, and it frees up a ton of time. So a 10 or 15-minute visit is like a really long visit for some folks. And the other thing is, you can bring them back. Like, if you put them on insulin and you want to see them back in 2 weeks, you can see them back and just talk about the insulin. So it's, yeah, it's interesting how I don't know that any of us spend a lot longer with patients, but the time we have is spent on more focused clinical stuff, if that makes sense. Sorry, that was a little long-winded. My colleagues might have other thoughts, but.
I mean, I absolutely agree. I think it's actually, it's more enjoyable if I'm able to talk to a patient and just do patient education. That's like I think that's the fun part of doing medicine, is like discussing the pathology, what's wrong, how can you improve, what can you do differently, what the medication does, what side effect to expect, things that our patients in the community would spend a lot of time getting lost in the internet searching. We're able to provide that education and just focus on kind of like doing the teaching part. And I think it's, yeah, I feel like I have a lot more time in the jail than in the community setting. Yeah.
Thank you for your answers. I didn't think that was long-winded at all. I thought that was really interesting.
Thanks. It's a really good balance. I think for all of us, I would say that variety, you know, it's one of the great things about primary care and working in a federally qualified health center that does a lot of different things.
Mhm. I'm sorry, I have a couple more questions if there is time.
Yep, there's time. Go
Okay.
right ahead.
I have two questions. One is, so like you mentioned, patients have no control really over anything in their lifestyle really in jail. And one of the things that we often say to patients is, you know, diet and exercise and nutrition. But if the patient doesn't have control over what they get to eat every day, how do you manage that?
I can start. I think that, thank you for your question. That's very very nice insight. I think every day I kind of have to reorient myself to where I'm at and reorient my education to the patient. And what I usually we just have to work around what they can get. They get their meals in two ways. There's the set meals, a breakfast, lunch, dinner, but there's also the commissary where they can access different foods. You know, that menu as well, it's also a lot of the foods it's unhealthy choices, and they have the option to purchase that. So what I usually just tell them is that if we do have certain diets that we can request from the kitchen to be, if you have a diabetic patient, we can request the diabetic diet. If you have a patient who requires a renal diet, we can do that, or a liquid diet and so forth. We're able to order those, but we're also able to like educate the patients on what they can order from the commissary, which is very helpful for them to know that of all the options they have, you know, they might have to cut back on buying as much snacks or a different you know, small little bite-sized cakes that they can buy, or things like that, or cookies, that certain things that they have access and they have options to not purchase. But we also can tell them certain things about, if you know, kind of educate what comes in their meal and what they should eat, what they shouldn't. As far as exercise, they have rec time, which is recreation time. Patients mostly decide to either contact family or shower, or some of them exercise before they shower. And so they have that time to decide what to do. And we can also recommend those things, you know, to exercise for a little bit, or sometimes I tell them to exercise in their cell before they get their rec time, so that when they do get their rec time, they don't have to spend that time exercising. Then they can call family or take a shower and those things. So we're able to kind of tailor our recommendation based on what's available to them.
Thank you. That's really interesting. And I wasn't aware that you could actually request diets or certain types of foods from the kitchen, which is really helpful. And then I had one more question, if you don't mind. I think about advocacy a lot in my future career in medicine, but don't always know, you know, what avenues are available. And I was wondering if you have incorporated advocacy into your life as a doctor now that you work with this particular population.
I think I'll let Dr. Donovan kind of, she's our administrator or our medical director at the jail, so I'm sure she has more access as far as advocacy. Personally, what I've done is a lot of the times kind of just started educating myself, since I'm kind of new in my career about the injustices going on. We do discuss with our the security staff as far as, you know, getting access for patients and how this can affect the health. So we do kind of advocacy within our site to our non-medical colleagues. And also there are opportunities within the residency where you can connect with different organizations around the DC area. But personally, I haven't got to that point. At this point, I'm just trying to learn more about the resources we have within the jail. But I would let Dr. Donovan speak about advocacy within the larger community.
Sure. So it's a really interesting question. So you can probably imagine, like, I'm essentially the medical director, and I oversee our clinical services there. And as a contractor, it can be hard sometimes to advocate in some traditional ways. You know, it's probably not an okay thing for me professionally to publicly like denounce something the Department of Corrections is doing because we're their contractor, right? And this is a, I think, challenge in medicine often. That doesn't mean I wouldn't take a stand if I really felt there needed to be a stand taken, but you really have to think about some of those things as you move professionally. But I think there are some opportunities that come up as part of our work. So I testify about once a year in front of the DC Council, and usually get asked some pretty hard questions. I'm personally a member of Physicians for Criminal Justice Reform. So there are some advocacy groups out there that if somebody's interested in this area of medicine, that one can become a member of. And then, you know, I think just locally in terms of advocating for patients, I do a good amount of education so that the systems, you know, systems are very siloed. So for example, over the past year, I've given grand rounds at Georgetown and George Washington University for ER and family medicine departments. Last year during the pandemic, I ran a couple of educational sessions for the public defender service and judges, trying to educate them about what we were doing in the jail at a time when we were getting lambasted in the papers. And I think a lot of folks who are typically might be our partners, you know, we're just sort of horrified by COVID and not understanding what we were really doing in the jail to fight the pandemic. So those are some, you know, things that I think we can do within work. But I would say in terms of like personal advocacy, Physicians for Criminal Justice Reform is where I probably stretch those muscles.
To add, to me, I think the advocacy is question like to whom you're advocating to. Whenever we always hear the advocacy, we tend to think about advocating to the legislatures and those who make laws and rules. But to me, just like advocating to our colleagues, what we do, advocating to like family members and like friends that, you know, the medical service exists in the jail. And then also, again, talking to the colleagues that is working in the jail is not as crazy as you think in TV shows. That always open up some minds. And then like what Dr. Donovan said, advocating to the next generation of physicians like you are, to hear that service exists and we are trying our best to provide a good healthcare to the most vulnerable people. So I'm not the greatest person to do the advocacy to the level of the government, but I do my own circle of friends and families and colleagues to talk about the jail. One more thing is that Dr. Donovan is a great advocate physician to the other outside of Unity healthcare, outside of the Unity's, the medical care colleagues. So for instance, we sometimes send the patients to the other hospitals for evaluations or even being hospitalized. She follows up almost daily for those who are very vulnerable and then maybe don't speak by themselves. again, we tend to think all of the incarcerated populations are in quote bad people. And even in the hospital settings, the care can be kind of bottom in the ladder compared to other patient populations. So we have to advocate our patients among our medical community, making sure that they are getting appropriate care while they're in the hospitals. And also when they come back, they have appropriate paperwork and then the discharge summaries and so on, so that we can continue the care as well. So again, like the level of the advocacy that you can do is probably different, but you can probably find somewhere that it fits with your interest and capacity that you have.
Thank you so much for your answers. That really helps me think about advocacy broadly and how I could try out some of those different ways in the future. Thank you.
And I would like to thank our entire panel tonight for providing such great information, and to Emily for your interesting and insightful questions that you ask. I'm going to stop our recording. And if you still want to stay on for a little bit longer, it's up to the panel, but we are almost to the top of the hour.